So continuing with the instruments that are important for undergraduate examination, in the last video we saw the difference between direct laryngoscopy and indirect laryngoscopy. Now we're going to continue with other scopes. This is a Chevalier-Jackson bronchoscope. First of all, how do you identify that this is a bronchoscope? Number one, there are two holes in front of the scope. These are the holes or vents that are used for the purpose of ventilation. So if your bronchoscope is in the right lung, then this will ventilate your left side. If it is in the left bronchus, then it will ventilate the right side. So this is very important. Also, the other end, that is the end that is towards the surgeon, there is going to be a vent for venturi. Venturi is for jet ventilation, for giving the air or oxygen. Because remember, when we are doing bronchoscopy, we are sharing the airway with the anesthetist. There is no intubation. The scope is placed in the larynx and then it goes in the bronchus. So how will the patient breathe at that time? The anesthetized patient will breathe through the oxygen that is given through this part of the scope, that is the air ventilation end of the bronchoscope. Now the other projection that you can see is to guide how is the beveled end of the bronchoscope oriented inside. So once the scope goes inside, how will you know whether your scope is in transverse or in vertical position? So this particular end will guide you how the beveling of the proximal end of the bronchoscope is. Now there is one very important concept that you should understand, that this bronchoscope is flattened from lateral sides because it has to negotiate the vocal cords which are oriented vertically when the patient is lying down. So this bronchoscope has to negotiate those vocal cords. Many times certain examiners ask that if I make holes in the esophagoscope, will it become bronchoscope? No, even if you make holes in the esophagoscope, the shape of esophagoscope is flattened anterior-posteriorly, which is how the esophagus is in our body. So esophagoscope and bronchoscope are not irreplaceable. Now this bronchoscope can be used for diagnostic as well as therapeutic purposes. For diagnostic purposes, of course, any kind of unexplained cough or respiratory obstruction or any kind of hoarseness of voice that you want to evaluate can be done with bronchoscopy or direct laryngoscopy. And therapeutic purposes, of course, like removal of foreign body or taking samples for bronchial lavage or for tuberculosis or any unexplained hemoptysis that you want to evaluate can be done by this bronchoscope. Any malignant mass can also be biopsied by using this bronchoscope. So both therapeutic and diagnostic purposes, bronchoscope can be used. The other instrument is esophagoscope. This is Negus esophagoscope. Now this esophagoscope is flattened anterior-posteriorly, as I told you, because that is how the esophagus is lying collapsed in our body. It is flattened anterior-posteriorly. This esophagoscope also has markings on it because that will help you identify the level at which there are the disease is when you do an esophagoscopy. The projection on the proximal end, of course, is for the orientation of how the beveling is inside the body. Now, illumination for both bronchoscope and esophagoscope is through a prism, through an external light source. Now, the use of esophagoscope is again diagnostic as well as therapeutic. Diagnosis is, of course, any unexplained dysphagia, any kind of mass in the esophagoscope that you want to biopsy or any sample that you want to take from esophagoscope. Therapeutic for taking biopsies, removal of strictures, or even removing foreign bodies. So therapeutic and diagnostic both. Now before we move on to other set of instruments, let me tell you that all the three type of scopes, esophagoscope, bronchoscope and direct laryngoscope, are done when the patient is lying down and there is extension at the neck. These instruments are all levered on the upper central incisors. So when the patient is lying down, these all instruments will be taking the leverage of the upper central incisors. So the common complications that you get from these instruments or these scopies is, of course, trauma and hemorrhage to the esophagoscope or bronchoscope respectively, but also damage to the teeth. and bleeding from the upper central incisors or loosening of teeth. These are common complications that you will have with these instruments. So this is about the scopes. Now we move to another very important instrument, that is your tracheostomy. In older days we used to do tracheostomy using metallic tracheostomies, but nowadays it is obsolete, and for all practical purposes we use Portex rubber tracheostomies, whether with cuff or without cuff, but these are all rubber tracheostomies. They stay more for a longer time without causing any kind of corrosive or reactionary problems. Now, first of all, the parts of this tracheostomy tube. This is the flange. This is going to stay on your neck. This is going to stay outside the body, and there are two holes on the sides of it, which is to tie or fix this tracheostomy either with a suture or with a ribbon gauze. The other part is this blue colored bulb that you can see. This is used to inflate using air. So if you can see, I would like you to come and take a close-up of this. So when I am taking out air, or when I am pressing in air inside this bulb, then there is inflation over here with air. Remember, we do it with air, we don't do it with saline, because in case this ruptures, then the liquid will be aspirated inside the lungs. So it is done only with air. So this is done so that there is no trickling of secretions into the larynx. Okay, but the disadvantage of this cuff is that it causes a lot of pressure on the walls of the trachea, and this may cause pressure necrosis of the tracheal wall or cartilages. That is why it is advisable that there should be deflation of this balloon timely. So especially when the patient is stable in the ward or in the ICU and this tracheostomy tube is in situ, every 2 to 3 hours you should deflate this tube. But during feeding of the patient, this should be inflated so that there is no aspiration. The other part of this tube is this purple colored pilot or obturator. The proximal end of this tube is sharp and may cause trauma. So when we insert the tube, we insert it with the pilot, so it is easy to insert, and then we will remove this pilot, and then the patient can ventilate to this end. There is one blue lining over here that very commonly examiners like to ask the students, what is this blue lining for? This blue lining is a radio opaque line. So when you have put the tracheostomy and you want to confirm that the tracheostomy is in the correct position, you can take an X-ray and confirm. The other ways to confirm that the tracheostomy tube is inside in the correct position in the trachea and not in the esophagus is of course by first of all doing suctioning, whether you're getting tracheal secretions or you're getting esophageal aspirate. Second is by doing auscultation of the patient. So when you connect it with an ambu bag and you ventilate the patient, you can auscultate the lungs and check whether the air entry in the lungs is proper or not. You can also connect it to a ventilator and check for the settings on the ventilator. They will guide you whether this is in the airway or not, whether it is generating the required tidal volume or not. And of course, as I told you, with this blue lining, you can take an X-ray and check whether the tracheostomy tube is in place or not. So these are the different ways how you can check for the tracheostomy. Indications and complications of tracheostomy you should read from theory, but the most important complications that you all should know about, one is of course placing it wrongly in the esophagus or in the false passage in the neck and not being in trachea. So that is the most important thing that you should know. And secondly, subcutaneous emphysema that can happen because of leakage of air in the neck spaces. The other complication indications forms a part of your theory which you should study from your books. After doing scopes and OPD instruments, we are now going to move on to instruments for surgery, and the most important surgery that we all at undergraduate level should know about is tonsillectomy. Today we are not going to do theory of tonsillectomy, we are just going to understand the instrument setup because it is elaborate and many instruments are required for doing a tonsillectomy. We are going to understand them. The first of all The position of the patient is going to be rose position, that is flexion at atlanto-occipital joint and extension at the neck. Below the neck, we will keep a rod that is called as Magarin's rod. This rod has got holes on which we will fix the Griffin's bipod. Now this is a bipod which will get fixed in this Magarin's rod like this. This will suspend what we call as the Boyles-Davis mouth gag with tongue depressor. This is a Boyles-Davis mouth gag. Again, like the scope, the hook end of this or the leverage of this instrument is going to be the upper central incisors. So this is going to remain in the mouth, and this is a tongue depressor. There are two types of tongue depressor. There can be tongue depressor with central perforation, which will keep the endotracheal tube in place, or they can be the one like this. The handle of this will engage in the Boyles-Davis mouth gag, and there is a lock system here, so we can fix it where at whatever level we want to fix, as to however mouth opening we want. So this can be adjusted. So if I want a mouth opening of this much, then I can lock it here. If I want more mouth opening, I can fix it over here. The size of this can be determined by keeping the blade between the angle of mouth to the angle of mandible. So you can measure. So if it's an adult patient, you will need a larger blade. If it's a pediatric patient, you will need a shorter blade. So you can measure the size of the tongue depressor by keeping it between the angle of lip to the angle of mandible, like this. So I would require help of one of my volunteers to arrange this setup to show you. This is a tongue, this is the Magarin's rod, this is the Griffin's bipod, just engage this. And this is exactly how this will get suspended. So once this is done, your both hands are free to perform the surgery. So this is the area through which we are going to remove the tonsils. The tongue is elevated up and the central incisors are down because the patient is lying down and we are standing on the head end of the patient. Remember, again, this is levered on the central incisors. To avoid any kind of trauma, we have kept some rubber tubings over here. This is the basic setup of doing a tonsillectomy in rose position. Now once this setup is done, we are going to use certain instruments to hold and dissect the tonsil. The first instrument is a Dennis Brown tonsil holding forceps. Now this is a atraumatic forceps. If you come closer and see the end of this, one part goes into the other. The upper part goes into the lower end. So this will not crush or cut the tonsil. This will just hold this. There is no grip or serrations. So it is not going to traumatize the tonsil. This is commonly confused with another instrument that we use in ENT, that is the Lux biopsy forceps. If you look at both the instruments carefully, in the biopsy forceps, the upper end and the lower end both grip exactly opposed to each other. So this is going to hold the tissue and crush it for taking a biopsy. Whereas this one goes one into the other. The other type of difference is that this has a box joint. So this is atraumatic. This is not going to cause any kind of trauma once you hold it. Whereas this has got a scissor kind of joint. So this, once you hold it, it is going to crush and keep that tissue with you so that it can be taken out for biopsies. So this is a Lux biopsy forceps. This is a tonsil holding forceps. So once you have taken the tonsil in your hand, the dissection is done using a Mollison's Mollison's anterior pillar retractor and dissector. So this has got two ends to it. The one end is a retractor which is used to retract the anterior pillar so that we get a good idea about the tonsillar bed and the bleeders that may be encountered during tonsillectomy. The other end is like a dissector which is used to dissect away all the fascias from the tonsil. We all know that the tonsil is in the between the anterior and posterior pillar on the tonsillar bed, which is formed by the lower fibers of superior constrictor, maybe some contribution from upper fibers of inferior middle constrictor, and lot of vascular tissue is there. We have got branches from external palatine vein and also from tonsillar artery, and the entire tonsil is held by the buccopharyngeal fascia. So to dissect away the muscle and fascia, we need a dissector. So this is Mollison's anterior pillar retractor with dissector. The other instruments that once we have dissected the whole tonsil out, we are going to cut and crush by using Eve's tonsillar snare. Now this has got a ring, wire ring on the proximal end. So how we are going to hold it? So let's say we have got tonsil over here. Can I get a gauze piece to demonstrate to the students how we can do the tonsillectomy? So let's say that this is the tonsil. We are going to first hold the tonsil with the tonsil holding forceps, pass this ring, and then from the lowermost end we are just going to cut and crush, and then this tonsil will be in our hand. So this is exactly how a tonsillectomy is done. So this is one of the method called as dissection and snare method. There are other methods of doing tonsillectomy, hot and cold methods like using a coagulator or harmonic scalpel or even lasers, cryosurgery. So these are different types of methods how you can do tonsillectomy. But this is very important that you must understand this is the conventional and still very commonly practiced method of dissection and snare technique. Sometimes when we encounter certain bleeders in the tonsil, then we use some specialized forceps and scissors for that. These are long Vogg's forceps, scissors, and a double curved artery. This is called as Wilson's artery forceps. This has got a double curved so that we can easily maneuver into the tonsillar fossa and hold the bleeders, either cauterize them or we can even ligate it. We all know hemorrhage is a very common complication. So understanding the different complications of tonsillectomy and indications of tonsillectomy is a prerequisite for undergraduate students. The bleeding in the tonsillectomy can be continuously suctioned by using a specialized suction. This is an atraumatic soft end suction. This is called as Yonkers suction. It is pronounced Yonkers. It is spelled as Y-A-N. So it's Yankers, but it's pronounced as Yonkers. So this has got multiple holes so that it doesn't take the tonsillar tissue with it.